impaired renal function. So just give me a minute to share my slides. Yeah, hello all. I guess I'm audible. Can I continue?
Yeah, please, Dr. Mahesh.
Yeah. So that's the topic for today, nephrotoxic agent and the various drugs that you use in impaired renal function. So basically my discussion, before we go into that, I would like to bring your attention to a clinical case scenario. So it's about a 84-year-old man who is suffering from type 2 diabetes. And this person was admitted to the hospital. And the reason for that was he was not responding to commands. It was an altered mental status with hypoglycemia. And when we took the history of the bystander, it was found that this person was having recurrent episodes of mild hypoglycemia over the last 7 to 14 days. 84-year-old man, so there's a possibility of other comorbid conditions, CLL, hypertension, and AF in this condition, in this case. And when we looked into the history, this person had a bout of pneumonia, following which there was an elevation of serum creatinine around 1.6 to 2.4. And for diabetes, what was the medication he was taking? It's an oral anti-hypoglycemic agent, sulfonylurea, glimepiride at a dose of 4 milligram twice daily. It's a drug, as some of you might be knowing, it's a drug which can increase insulin secretion from the beta cells of pancreas. So this increase in insulin secretion will be independent of blood glucose level, which means even if the blood glucose level is normal, it can enhance insulin secretion. So there's always a possibility of hypoglycemia, especially this drug being a long-acting agent. Another drug which was being taken by this patient is a hypolipidemic agent, the HMG-CoA reductase inhibitor atorvastatin. And when it was inquired in detail, it was found that because of the fear of hypoglycemia, because of these frequent hypoglycemic episodes, this person, 85-year-old man, had a tendency to skip oral anti-diabetic agents. So when you looked into the laboratory parameters, glycated hemoglobin was slightly on the higher side, but not of utmost concern. And creatinine levels was also above normal. Lipid profile, nothing much of a concern. So this is a case of a patient who is on oral anti-diabetic agents plus hypolipidemic drugs. Glycated hemoglobin is under control, but the serum creatinine is on the higher side. So impaired renal function is starting to slow in that patient. And the problem is frequent episodes of hypoglycemia. So a normal situation in an elderly male, glycated hemoglobin might be normal, blood glucose control could be normal, creatinine levels slightly on the higher side, denoting probably telling us that yes, there is a possibility of impaired renal function and frequent episodes of hypoglycemia, which is complicating the whole clinical scenario. Now, what do you do in this patient? The patient, elderly male with other comorbid conditions, complaining frequent episodes of mild hypoglycemia in an individual with impaired renal function. What's the solution? We'll see towards the end. So my discussion basically for today will be concentrating on what's the relationship between drug and kidney. If there is a problem in renal function, what's so important to know about the drug details. Second one, I'll briefly look into the pharmacological aspects of impaired renal function. What exactly are the PK, which stands for pharmacokinetic, and PD, which stands for pharmacodynamic changes in an individual with impaired renal function? How do you assess the renal function, especially with respect to dosage of drug? And what do you do? What are the considerations that you take into account when you probably moderate the drug dosing regimens, when you try to manipulate the drug dosing regimen? And I'll be concluding my session with the nephrotoxic agents and what are the ways by which a nephrotoxic agent damages the kidney. So we'll start with the discussion. Yes, the first one, what's the relationship between drug and kidney? Yeah. So why is it so important? Why kidneys are very important when you talk about drugs? One reason, renal blood flow is 25% of cardiac output, which means that there will be a lot of drugs, lot of molecules which enter into the kidney. And how do they enter into the kidney? Either by glomerular filtration, that is one way by which the drugs enter or any molecule enters the kidney. And the other way is it can be actively secreted into the tubular lumen with the help of cationic or anionic transporters. And this can happen against the concentration gradient. So which means that molecules, especially the drugs, because of high excessive renal blood flow, get concentrated in the kidney via the glomerular filtration and the tubular secretion. And one thing that can happen is, you might be knowing, if you talk about the loop of Henle, when this drug passes through the loop of Henle, what happens is water gets reabsorbed. When water, yeah, hello? Hello? Can I continue?
Yes, you can, please.
Yeah, thank you. So what happens is when these drug molecules, when they travel across the loop of Henle, some of the water molecules are reabsorbed back into your body, which means the concentration of the drug as it approaches the ascending limb of loop of Henle and distal tubule collecting duct, it's more concentrated, which means there is a high potential of these drugs entering the tubular epithelium and damaging the tubular cells. So that's one problem. And another changes which can happen, the last point, the changes which can happen within the renal macro environment. I'll give you an example. We all know that liver is the primary organ which is responsible for metabolism of a drug. But kidneys are also responsible. You have those enzymes, the cytochrome P450 enzymes, which can metabolize a drug into inactive products. So when these CYP450 enzymes metabolize a drug, as a byproduct, the free radicals can be generated, the oxygen species can be generated, which again can be toxic to the tubular epithelial cells. So that's another issue that you may face because of the drug changing the microenvironment of the kidney. Another example, I'll give you an example of a drug, methotrexate. That's a drug which gets precipitated in the kidney in an acidic environment. And you know the pH, that's acidic. So the problem is when you take drugs like methotrexate, it can crystallize in the kidney, which means crystallization, concentration within the kidneys could again add insult to the injury. So that's the relationship that we can have. That's the reason why kidneys are so important when you talk about drugs. Now, in brief, I know we are going to get into core pharmacology, but I'll try to simplify the concepts. I'll go through it superficially. We want to know what are the changes that can happen, the pharmacokinetic changes and the pharmacodynamic changes that can happen when the kidneys are not functioning properly, the CKD, the end-stage renal disease, the acute kidney injury. What are the factors that can affect the PK and PD of a drug? Now, pharmacokinetics, you would be knowing, it's what basically the body does to the drug. What does the body do? When the drug is entering, when you give a drug, it gets absorbed into the systemic circulation. The systemic circulation ensures that the distributed to various parts of the body, including the site of action. But the drug is not going to remain eternally in your body. The drug is going to be eliminated from your body. How does it do that? First, the drug is getting converted into inactive products. You call that as metabolism. And then the drug is excreted via the kidney. So that's the pharmacokinetics, what we call as absorption, distribution, metabolism, and excretion. So that's pharmacokinetics. Now, what is pharmacodynamics? What the drug is going to do to the body. Why do you take a drug? To produce an action. And that comes under the realm of pharmacodynamics. So our question is there any change that can happen to the kinetics of a drug or dynamics of a drug when there is an impairment of renal function? And the answer is yes, there would be a change. Let's look into that. So this is kinetic in brief. When you give a drug orally through the intestinal epithelial cells, it gets absorbed through the portal circulation. The drug is going to reach first the liver. The liver here itself might metabolize the drug, convert the drug into inactive products. You call that as first pass metabolism. And from here, the drug reaches the systemic circulation. If you're giving a drug parenterally via injection, the drug is going to reach directly into the systemic circulation. There's one thing that can happen in the systemic circulation. This drug that you give will be available in two forms. One, the form which is bound to a plasma protein, either albumin in the case of an acidic drug, or alpha-1 acid glycoprotein in the case of basic drug, or it would be in the free form. Take, for example, warfarin. When you give this drug warfarin, 99.9% of the drug would be bound to plasma protein, whereas only the 0.01% of molecules will be the free form, the one which is responsible for action of the drug. So that's happens when the drug is in the systemic circulation. And what does the systemic circulation do? Distribute the drug into various parts of the body, intracellular, extracellular, including the site of where you want the drug to act. So during this distribution, obviously the drug is going to reach the liver. Liver ensures that the drug is going to be inactivated, what we call as metabolism. And finally, after inactivation, the drug reaches the kidney, which is the one responsible for excreting the drug. So that's pharmacokinetics. Now, what are the changes that can happen in an impaired renal function patient? One thing, I'll try to cite examples. Now, what can happen is, if in a renal disease, say for example, nephrotic syndrome, there is a possibility of gastrointestinal edema, renal damage, uremia, there's a possibility of vomiting. In these cases, there will be decreased absorption of the drug. A typical example being a loop diuretic furosemide. In the case of vomiting, the amount of time spent by the drug in contact with the intestinal epithelium would be less. So the natural conclusion would be absorption would be less. Another scenario, probably again in a kidney disease, uremia, there is decreased elimination, there's a breakdown of proteins, but urea, creatine, they all get increased, they're not excreted. So what's the problem? The problem is alkalinization. So in an alkaline environment, acidic drugs would be retained, would be excreted, whereas the basic drugs would be reabsorbed. So there will be an increased absorption of alkaline drugs. I repeat, in an alkaline environment, acidic drugs would be more ionized, so absorption would be less. But in an alkaline environment, alkaline drugs would be absorbed more because the degree of ionization would be less, lipid solubility would be more. The one confusing aspect as far as absorption and distribution is concerned, I'll try to clear it with an example. And that example is, I'll try to cite that example. Look at amikacin, which is an aminoglycoside, and the other one, gentamicin, which is also an aminoglycoside. Now, these two drugs, amikacin and gentamicin, The volume of distribution for amikacin is 0.20 liters per kilogram. For gentamicin, it's again the same. But in a chronic kidney disease patient, stage 5, the volume of distribution is increased. Why is it so? Because there will be more amount of fluid. When there is more amount of fluid, for hydrophilic drugs, the volume of distribution would be more. Now, what is volume of distribution in simple terms? How much volume is needed in the body for the drug to get accommodated? That's volume of distribution simple. So volume of distribution is nothing but how much volume is needed in your blood to accommodate that drug. So for hydrophilic drugs, it's more to do with water. And this is an hydrophilic drug, which means amikacin and gentamicin. In CKD patient, the volume of distribution increases. So that's it. If the volume of distribution increases, should we look at some dosing? Yes. What kind of dosing gets affected when you talk about volume of distribution? It's the loading dose. What is the loading dose? It's the dose that you give abruptly. Why do you give it? So that the steady state concentration is attained faster. Now, in clinical practice, we have a tendency. If a person is having impaired renal function, we all have a tendency to reduce the dose. But now we have just found out if the impaired renal function in a CKD patient increases the volume of distribution, obviously the loading dose, that is the dose needed to attain the steady state plasma concentration faster, that also needs to be increased rather than decreased, because loading dose will always depend upon the volume of distribution. So higher the volume of distribution, higher the loading dose. And when does the volume of distribution increase? Yes, you can see here in CKD patient, increased amount of fluid. So apparent volume of distribution increases. So you need to alter the dose. Which dose am I talking about? The loading dose, not the regular maintenance dose. So always remember, volume of distribution can affect the loading dose, and volume of distribution can be affected in CKD patients. Now, the other concept that we are talking about, plasma protein binding. So this yellow molecule is the plasma protein, albumin or alpha-1 acid glycoprotein. As we have seen, when a drug enters the bloodstream, some of the molecules get attached to the plasma protein, some do not. The drugs which do not attach to plasma protein, they are called as the unbound fraction or the free form. Whereas the drug which is attached to the plasma protein, it's called as the bound form of a drug. Now, what happens is, in a patient with kidney disease, in a patient with uremia, what happens normally is, because of certain toxins produced, because of certain conformational change in the plasma protein, the ability of the molecules to bind to the plasma protein, as you can see in a normal scenario, is significantly changed when you look at the ability of the drug molecules to bind to the plasma protein in uremia. Which means, if in a normal hypothetical situation, if 5 drug molecules are binding itself to the albumin, in uremia, the number of molecules which bind to albumin would be less. What does that mean? If less number of molecules are bound to plasma protein, the free form of the drug increases. What's the problem when the free form of the drug increases? Effect increases, toxicity increases. Even though pharmacologically we often exaggerate the situation, clinically does not proven to be that much significant, luckily. But we'll take an example for this. So these drugs, acidic drugs, as we were telling in the previous slide, bind to albumin. So in a normal patient, if this is the unbound fraction, which means the free form of the drug, what has happened in a person with end-stage kidney disease? The free form increases. The free form of the drug has increased humongously when you look at the percentage wise. Why is it so? Because the ability of the drug to bind to the plasma protein, that is getting hampered, that is getting affected. So the free form increases, so you always have to be cautious when you're dosing, because when you give the normal dose, problem in an end stage kidney disease patient is the free form of the drug will be high, which means there is a possibility of toxicity. Drugs like phenytoin come under that regard. But if you watch closely at these basic drugs, if you watch closely, normally if this is the free form, what has happened in end stage kidney disease? The free form has decreased. Now, what could be the reason for that? Because basic drugs don't bind to albumin. Basic drugs bind to alpha 1 acid glycoprotein, which can get increased in acute and chronic inflammatory conditions. So if you are talking about basic drugs, beta blockers, propranolol, some of the opioid analgesics, the free form actually decreases. Why is it so? Because the plasma protein which binds to the basic drug, that increases the alpha 1 acid glycoprotein. So that's the difference between the free form when you're talking about acidic drugs, when you're talking about basic drugs. Now, after the drug gets distributed, after the drug produces an effect, our body is waiting for the drug to be eliminated. Now, again, necessary for all the drugs, for all the drug doses to be reduced when you are giving it to a patient with impaired renal function. Let's figure out what is the importance of this particular FE. Now, what is that? We'll see an example. Suppose if a drug, so this is a drug which 10% of the drug is excreted unchanged by the kidney. Either the drug without any metabolism, the active drug is getting excreted unchanged by the kidney. How much percentage? Only 10%. 50% of the drug is getting converted into inactive metabolite. I repeat, inactive metabolite M1, and all these M1 metabolite is getting 100% renal excreted. Whereas 30% of the drug is getting converted into another metabolite, which thankfully is again inactive metabolite M2. 100% of the drug is getting renally excreted. And the remaining, I'm sorry for the percentage, it's 10%. And the remaining 10% of the drug is getting cleared via the biliary tract. This is not 50%, I'm sorry, this is 10%, which means out of the total amount of the drug, it's only 10% of the drug which is getting excreted unchanged. All the other proportions of the drug is getting either excreted via the kidney in an inactive form or getting excreted via the biliary tract, which means what is the fraction of the drug excreted unchanged by the kidney or excreted by the kidney as active metabolite? What is the fraction? It's only 10%. You call that as FE. And if the total renal excretion of the dose here is 90%, but what are we more concerned with? We are not concerned with how much percentage of the drug is getting excreted via the kidney. I'm sorry, we are not concerned with that. What are we concerned with? We need to know what percentage of the active drug is excreted via the kidney unchanged. We need to know what percentage of the drug is getting excreted in the form of active metabolites. So active metabolite plus unchanged drug, how much percentage is getting excreted via the kidney? In this case, it's 10%. So we need not worry. Why? When do we have to modify? When do we have to look with concern? when you give drugs which have a predominant renal excretion, when this fraction, what we call as Fe, is greater than 25 to 50%. What is Fe? It's the fraction of sum total of active drug plus toxic metabolite, which is excreted via the kidney. Some of the drugs which need our attention, some of the opioids, morphine, which has morphine 3 glucuronide and morphine 6 glucuronide. Tramadol, the desmethylated derivative of tramadol, which is an active metabolite, can cause CNS side effects. And of course, the well-known meperidine, formerly known as pethidine, which can produce two metabolites, mepidinic acid and normeperidine, where the demethylated normeperidine can cause seizures, CNS toxicity. Another antidepressant, the atypical one, venlafaxine, its demethylated metabolite is also active and it is excreted via the kidney. So when you give these drugs, which have a predominant renal route of excretion and which can excrete the drug either unchanged or by producing toxic metabolites, that is when you need to consider dose modification. So merely renal excretion of drugs doesn't warrant dose modification. When the renal excretion is in the form of active substances, that is when eyebrows are raised. So when you're giving drug to a person with impaired renal function, is it necessary? Is it justifiable? Is it cost effective to assess the renal function for all drugs? No, you need not do that. For which kind of drugs you need that? So which kind of drugs will have our attention? Those kind of drugs, number one, I would say, I'm sorry, I'm not able to write this. I would have preferred writing, but I'm trying to figure out in Zoom. Yeah. What are the factors? What kind of drugs do you think when given to a patient needs renal function assessment? Number one, drugs which are eliminated via the kidney. Yes, you need to think that. If they have a predominant renal elimination, yes, now you consider. Does that mean that all drugs which are eliminated via the kidney need our attention? No. What is the next thing? The next thing is whether it's the active metabolite and the unchanged drug getting excreted. Then your attention should be more. So that's next point. What is the next thing that you have to be concerned? The next one, drugs which are having a narrow therapeutic index. When you talk about penicillin, the predominant excretion route is tubular secretion, which is renal elimination for penicillins and semi-synthetic penicillins. But these drugs, they are not having a narrow therapeutic index. If there is a small increase in plasma concentration, it's not going to result in dangerous adverse effects. So those drugs, yeah, there's a little comfort, there's a little cushion when you give these drugs. So do those drugs need renal function assessment? Number one, drugs which are not eliminated via the kidney, you don't need to do that. Yeah. Drugs, the form of drugs which is eliminated by the kidney, if it is more inactive, do you need to have a renal assessment? I'm afraid not. Drugs which are very safe, wider therapeutic index, do we need to know for those kind of drugs? No. Then what kind of drugs you need to have a proper renal function assessment? Number one, drugs which are less safe, which are having low therapeutic index, narrow therapeutic index, small increase in the plasma concentration of the drug. If that leads to toxicity, that's a dangerous drug. Those are the drugs where you need to look for. Other kind of drugs which are eliminated via the kidney in the form of active metabolites, in the form of unchanged drug. Those drugs need to be assessed before you give them. And as far as drug dosage is concerned, you can classify renal impairment into mild, moderate, severe. Normally, if it's greater than 30, you need not think about dosage alterations. But if it's moderate to severe, yes, you need to think about. You need to find out which appropriate drug dosage regimen should be introduced in that particular patient. And the usual formula that we all follow, though we have the MDRD formula as well as the CKD-EPI formula. MDRD stands for modification of diet in renal disease, and CKD-EPI, that's the chronic kidney disease epidemiological collaboration. But the formula that is very widely accepted, because the other formulas can probably underestimate or overestimate the impairment in renal function. So that can lead to overdosage or underdosage of certain drugs. And what's the formula? That's the Cockcroft-Gault formula, which talks about creatinine clearance, which is nothing but 140 minus age in years into body weight in kilograms divided by serum creatinine into 72. Comparatively easier to calculate. And if it's a female, you need to multiply the entire figure by 0.85. So after assessing the creatinine clearance, you make appropriate dosage changes. Now, how do you do that? What's the common practical way that you can adopt? What are the drug dosing considerations that you need to look at when you're treating a person with impaired renal function? Do you directly go into the Cockcroft-Gault formula, or do you have a detailed history? Do you look into the clinical aspects? What is the clinical situation? Do you clinically assess the patient before you decide the drug dose? Yes, it's always good. When you're dosing a drug in a person with impaired renal function, the first thing is you should be aware that the person is having an impaired renal function. That's the first thing that should be there in your mind. So how do you approach a patient with impaired renal function when you're giving a drug which satisfies these criteria? Take a proper history, and then serum creatinine level will help you in estimating the creatinine clearance. Cockcroft-Gault equation will help you in this regard. And then you try to look at the other factors, the comorbid conditions, the age, all these factors before you decide a treatment regimen. And if the treatment regimen is working fine, if it is producing the effect that you want, if it is not producing the adverse effects that you're afraid of, continue with that. But if in any of these parameters, either a reduction in efficacy, either a worsening of the clinical condition, or the emergence of adverse effect, if any of these things come up in that patient, you have to revise the regimen in a more effective manner. And the common method that we usually adopt, dose scheduling in renal impairment based on the creatinine clearance, you have three methods. One is called as the interval method, one is the dose method, and the other one is a combination of both the interval and the dose method. And just go through it briefly, just superficially, to understand what is this dosage schedule called as the interval method. What do you mean by dose method? What's the combination? Now, if this blue line, if that is the dose schedule in normal renal function, we look at the graph where on the y-axis, it's the concentration of the drug, whereas on the x-axis, it's the time, the frequency of administration. So in the interval dose, what is happening is, if a drug is given more frequently, look at the space here, it's more frequently. If a person is having renal impairment, you give the same dose. So there is a same rise in plasma concentration, but you don't give it frequently. The frequency is reduced. You give it after a long period of time, which means the dose given is the same. So the rise in plasma concentration would be the same, but the frequency of administration would be less. So the drug is given in the same dose after a longer period of time. This is especially adopted for drugs whose efficacy depends on the peak concentration. Say, for example, again, the well-known example, aminoglycosides, gentamicin, amikacin. So their ability to kill the organism is depending on the peak concentration. You don't want to compromise on that because they follow concentration depending killing. They have post antibiotic effect. So those kind of drugs, you increase, sorry, I beg your pardon, you decrease the frequency of administration. So that's the interval dosing. The interval of drug administration is increased. So frequency becomes decreased. Now, what is the other one? The dose schedule. What is that? Suppose if the blue one is the dosing that you're going, dosing schedule that you adopt in a normal person, what has happened in a dose schedule in renal impairment? What has happened? The dose is decreased. So the plasma concentration attained, the peak plasma concentration, what we call as Cmax, that would be less. But the scheduling, the frequency, it's the same. Now, what's the third one? No guesses. It's an easy one. What's the one? The combined one. What do you do in that? Yes, what do you do? The orange line. The maximum, the dose is also decreased. So the plasma concentration reduces, the peak plasma concentration, whereas the interval of administration, that is also prolonged. The frequency of administration. If it were to be thrice daily in a normal individual, we convert it into twice daily or once daily. So this combined method, where you decrease the dose as well as the frequency of administration, drugs like digoxin would warrant such a dosage schedule. So if you could see this table, that would make it clear. So if the GFR is not of particular concern, that's the first column. GFR, yes, it's of concern, 10 to 50 milliliter per minute, and GFR, if it's very low, what do you do for drugs? Say, for example, acyclovir, what do you do? The same dose is given, but what is the frequency? It's less. So that's the interval dosing that you do. What about allopurinol? What do? You just decrease the dose. So that's the dose schedule that you follow. And for drugs like digoxin, let's see whether we have digoxin. Yes, digoxin. Yes, if this is the normal frequency of administration, if the GFR is getting reduced, look at the frequency of administration. That is also getting increased. Frequency is getting lowered. You give it once in 2 days. And what about the dose? Dose is also reduced. So you need to look at all aspects when you give drugs with narrow therapeutic index, and digoxin falls into that category. Now, nephrotoxic agents in impaired renal function, it's always better. If you have a better alternative, go for those drugs. Now, how do these drugs, the so-called nephrotoxic, how do they cause toxicity? That's the question. The three major mechanisms that is being proposed. One, idiosyncratic reactions, which is totally unexpected. You give an agent, and not based on its pharmacological properties, it can cause a reaction which can be permanent damage. That's an idiosyncratic reaction. The well-known example, we have many examples like chloramphenicol causing aplastic anemia. So those are examples. Now, idiosyncratic reactions, the interstitial nephritis caused by many drugs, under which comes NSAIDs, proton pump inhibitors. So they all are idiosyncratic reactions. What is the other way by which these drugs can damage the kidney? By reducing the blood flow. Probably the afferent arterioles getting constricted, the GFR getting reduced. So that's the hemodynamic related changes. The AC inhibitors, ARBs, NSAIDs, amphotericin B, they all cause these hemodynamic related changes. And what is the other mechanism by which certain drugs can damage the kidney? They get into the tubular epithelial cells. They do a direct toxic effect, damage the tubular epithelial cells. They may create pores within the epithelial membrane. There will be leakage of electrolytes. So that's the direct tubular damage. Again, amphotericin B, it's a perfect example for such a drug. Platinum compounds used in cancer chemotherapy, glycopeptide antibiotics. So these are drugs which can cause a direct tubular damage on the kidneys. Now, some of the common examples of drugs, aminoglycosides, AC inhibitors, ARBs, amphotericin B. So the mechanism that I was talking about, aminoglycosides getting concentrated with the help of endocytosis, megalin, and a direct toxic effect on the tubular epithelial cells. Now, what do you do if aminoglycosides, we know nephrotoxic, what do you do? What is the best thing that you do? Search for an alternative. If there is an alternative drug, give it. Now, you don't have a choice. Then what do? Never give multiple daily doses. Single daily dose, less renal damage. And always, it's always better if you do a TDM, therapeutic drug monitoring, and measurement of serum creatinine. And if the creatinine is worsening, no, stop giving the drug. So always for these kind of drugs, a better alternative, if it's there, go for it. If it's not there, try to find out if there are any methods that you can adopt when you give these drugs in those kind of individuals. So impaired renal hypoperfusion, never give AC inhibitors, ARBs. Bilateral renal artery stenosis, that's one of the contraindications of AC inhibitors and ARBs. So these kind of drugs, foscarnet, indinavir, cidofovir, hydration would help. And cidofovir, one thing that you can do is you can give probenecid with it, because probenecid will reduce the tubular secretion of cidofovir. So less amount of the drug reaches the kidney. So that is one method that you can adopt when you give this drug for CMV retinitis, cidofovir. Now, other examples, yes, analgesic nephropathy, tubular interstitial nephritis, yes, lymphocyte infiltration, we are talking about NSIDs. So always avoid the use in these kind of individuals. And if it's a nephritis, corticosteroids would be a drug that you can introduce, similar with proton pump inhibitors. Yes, platinum compounds, I was talking about this, tubular cell death can happen with the generation of free radicals. Calcineurin inhibitors, cyclosporin, tacrolimus, prostaglandin getting reduced. So again, the blood flow to the kidney, use glutathione levels, that also gets depleted when you give these immunosuppressants called as cyclosporin, tacrolimus. What's the solution? You give an immunosuppressant which is not toxic to the kidney. The mTOR inhibitors, they're always a better option. Sirolimus, everolimus in these kind of individuals, because they don't damage the kidneys. So finally, if I conclude, it's when you assess the renal function based on creatinine clearance, yes, it will always help you as a guide in selecting the dosage regimen. But clinical parameters, clinical assessment should be given predominant concern along with these lab findings, along with these assessments, before you make a clinical judgment, before you decide which drug to be given, at what dosage to be given. Is there a need to reduce the dose? If so, how do you do that? And if there is a need to change the drug, if there is a need to change the drug, what are the other suitable alternatives? Also wanted to give a problem based on this. We could have had a discussion, but because of paucity of time, I'd be concluding. I'll just make a remark, and that is, when you give a maintenance dose of a drug to a person with renal impairment, I repeat, when you give a maintenance dose of a drug with renal impairment, there is a tendency among some to reduce the dose based on the impairment in renal function. I'll give you an example with which I'll be ending this session. Suppose if a drug, the normal dose of a drug is 100 milligram. If you give this 100 milligram maintenance dose to a person whose renal function is only 20%, 20% renal function. Should you reduce the dose to 20 milligram because the renal function is only 20%? No. Before you do that, you need to find out what is the percentage of the drug which is excreted by the kidney. If the drug is excreted 100% by the kidney, then yes, if the renal impairment is 20%, if the renal function is only 20%, the dose should be reduced to 20 milligram. But suppose if only 50% of the drug is eliminated via the kidney, what does that mean? Out of 100 milligram, 50 milligram doesn't have any issues. It's the remaining 50 milligram which has got issue, where the renal function will come into picture. So the dosage of the drug which is eliminated only 50% by the kidney, that dose will not be 20 milligram. It would come around, by calculation, it would come around 60 milligram. So when you reduce the maintenance dose of a drug which is excreted via the kidney, two things that you have to look for is, one, how much amount of the drug is excreted via the kidney, and second, what is the renal function of that person. And the clinical scenario which we're discussing, which I had introduced in the earlier part, how do you tackle this? Type 2 diabetes, a sulfonylurea given, glycated hemoglobin is not an issue, but the problem is creatinine is on the rise and frequent episodes of hypoglycemia. Now, what do you do for this patient? You need to have a patient-centric approach. Elderly individual, there's a possibility of impaired renal function. Elderly individuals, the drugs will have a longer action. So there is a high possibility of hypoglycemia. So what do you do? Elderly individual, do you have the same target values? Are you very particular in having a glycated hemoglobin 6.5, creatinine coming down to 1? No, you will have certain kind of relaxation. So what is the solution? You have to attain glycemic control, but reduce the risk of hypoglycemia. How do you do that? You introduce an anti-diabetic agent, oral anti-diabetic agent, which will not be eliminated via the kidney and which has got less chance of hypoglycemia. Which is that drug? You give gliptin, linagliptin, because the other gliptins, the DPP4 inhibitors, the other ones have a renal elimination. Linagliptin, non-renal elimination. So you introduce linagliptin, which has got a non-renal elimination, minimal risk of hypoglycemia because it increases insulin secretion depending on blood glucose level. That's the advantage. And then for better glycemic control, you can also think about adding at low doses a long-acting insulin analog, insulin glargine or Ditamin, and then have a periodic checkup. So you won't have one solution, one particular solution for every patient. Promote patient-centric approach. Look at the parameters of that particular patient. What is your objective, and which are the drugs which can help you in attaining that objective? So always in an elderly individual, yes, there's a possibility of impaired renal function. Think about the drugs with non-renal elimination. That might probably give you a solution for some of the problems. Thank you all. Thank you for your patient listening. These are my references. Thank you for your patient listening. I knew the topic is a big, vast, humongous, but I've just talked about the salient features superficially. Thank you for your patient listening. Thank you.
Thank you, Mahesh, for that wonderful presentation. So actually, it was more of a clinical oriented approach. So majority of the practitioners' questions you have answered. So thank you for that wonderful session. So students, do you have any queries or any questions? You can just unmute yourself and you can ask Dr. Mahesh. We have a couple of minutes for that. If you don't have any, we'll conclude the session. I hope there is no questions. So once again, thank you, Dr. Mahesh. So
Thank you.
yeah, so we
Yeah,
will
thank
meet
you.
tomorrow the same time. We'll be coming with the next topic. So until then, good night. Bye.
Thank you all. Thank you.